my pleasure to welcome Dr. Michael Tam, who's back here after a period of time away from UNSW to present today. So Michael is a staff specialist at Fairfield General
Practice Unit.
Practice Unit, and he's had a reasonably long association with the School of Public Health here, involved in particularly in the medical program here, and he still remains involved in teaching. I presume you see quite a few students down in your unit. So Michael also has active research interests in, really I think in terms of things like comorbidity and substance use in adult patients. And he wants to talk today a little bit about this area of interest. So his title is Detecting Risky Drinkers in General Practice, and why we aren't doing very well with that. So I'll let Michael tell you more about that. Thanks very much for coming.
Thanks for that, James. So I'm Michael Tam. I know some of you, but not others. I worked here for almost three and a half years before leaving the position to go to the General Practice Unit at Fairfield Hospital a little bit over a year ago. And my work there involves clinical practice, supervision, education training, health services development with the LHD, integrating care with community general practice, and also some research as well. And as James mentioned, my clinical interest is really in the caring of people living with comorbid substance use and mental illness. My research has mostly been around understanding the beliefs and attitudes that surround alcohol discussions in GP consultation rooms, and I'm very grateful to have been given the opportunity to speak on this topic as a novice researcher, as this presentation is really a story about my research journey so far. And so my story really begins in the summer of 2010. I was in the graduate diploma year in a postgraduate mental health qualification through the New South Wales Institute of Psychiatry at the time. And rather than enjoying the sunshine in the summer, I was doing some coursework in a course looking at dual diagnosis, so people with both substance use disorders and mental health disorders. And one of the learning activities as part of that course was that I had to have some experience using a screening instrument, so an alcohol screening instrument, the audit. And the specific activity involved using the instrument on 5 consecutive patients and then reflecting back on the experience of doing so, the results I gathered, and what that meant. And I recall at that time how difficult it was to use the screening tool. Of the 5 patients, 3 of them scored positive as being at risk of being a risky drinker. One was expected, someone I knew who had a drinking problem. 2 were not. And at the time I thought, well, this is interesting. You know, I've just sort of detected a couple of my patients who probably had a bit of a drinking problem, but those consultations ended up being quite long. They didn't come in for those problems. But the really interesting thing afterwards was that after the exercise, I felt absolutely no inclination of using the tool again. And I didn't think about it so much at the time, but afterwards I just thought, you know, I'm a fairly reasonable GP, I think. So what's going on there with this tool? Why did I find the tool interesting and useful, but actually felt that I couldn't implement it? And so by mid-2010, so I'd completed that unit by then, I had an opportunity of joining UNSW at that point. There used to be a joint GP Synergy University of New South Wales position for GPs looking at sort of breaking into academic practice, both teaching and also research. And I was lucky enough to be successful in that position. I should have really moved the slides along, actually. That's the audit, by the way. So the alcohol use disorders identification test So I asked some consumption questions and he scored positive on that, and he asked some more questions about harm and things of that nature. So by mid-2010, I applied for this joint position. I was successful. But I told Nick that I'd already planned to live in France for 6 months, and so I did. And I started my association with UNSW as a staff member really in 2011. So prior to that, I was mostly just seeing students in my rooms. And as part of that position for a year, I had the expectation was that I would do a research project. So I sort of reflected on my experience from a year before. What is it about asking patients about their drinking in practice, particularly what is it about the audit that made me feel like I couldn't use it. So that became my sort of topic of research for that year. And so, as with research projects, first thing I had to do was to go to the library, have a look at the literature to see what's there. And as I was sort of reading up on the topic, it was actually kind of depressing, actually. This is the sort of stuff that comes out when you look up literature about GPs detecting drinking. Very negative perspectives out there, and so negative attitudes, lack of training, professional lack of confidence, low levels of commitment, and that's just in the title and the abstract. And interesting to me was that even though this is a particularly critical paper, none of the authors there are GPs or involved in general practice. I thought, reading sometimes just makes me feel very sad as a GP, but maybe they were onto something there. And in the context is about 1 in 4 people in the general community, 1 in 4 adults in the general community, somewhere about 1 in 4 to up to 1 in 3 adult patients in general practice are risky drinkers, so drinking alcohol in such a way that potentially places them at harm. And what is risky drinking? Conceptually, it's reasonably clear, so a pattern of drinking that places an individual at increased risk of alcohol-related harm. How that's operationalized is complicated, and there's substantial disagreements on how you actually measure or work out someone is a risky drinker or not. In Australia, the NHMRC released their drinking guidelines in 2009, so the last drinking guidelines in 2009, and I'm not sure if anyone's ever read through this document in depth. It's a curious document that tries to do many things. They don't, in the 2009 document, they don't describe what is risky drinking. In fact, they explicitly say they don't want to describe risky drinking as a threshold anymore. From a philosophic perspective, that risk is a continuum. But they do describe low risk drinking, which for most adults, men and women, is 2 standard drinks, that being the Australian standard drink. The difficulty with this, of course, is that the concept of risky drinking is sort of broadly used in alcohol research. And so this gets to the point, is drinking more than low risk drinking risky drinking? We can't answer that from the document, but that's the way the Australian Institute of Health and Welfare and Health interpreted that in all subsequent epidemiologic studies on risky drinking, that anything more than low risk is risky. Is that right? I'm not so sure. The very concept of a standard drink is quite interesting. Anyone know what the standard drink in the UK is? It's 8 grams. And the standard drink in the US is 14 grams of alcohol. It's surprisingly non-standard, the standard drink. 10 grams sounds nice, but I actually, the UK standard drink of 8 grams is 10 mils of ethyl alcohol. So that's their definition. It ends up being 8 grams. I actually quite like the US standard drink. The US standard drink is basically the amount of alcohol in one beer, basically. One bottle of beer ends up being one standard drink, while for Australia, one bottle of beer ends up being 1.2, 1.3, 1.4. A normal glass of wine, again, ends up being about 1.3, 1.4, while the standard drink of a glass of wine being some 90 to 110 mils, no restaurant pours that amount of wine as a glass of wine. But it's a surprisingly non-standard thing, and this is something to keep to think about when you read sort of international literature on drinking. When they talk about standard drinks, it sort of depends on where the authors come from, by what they mean by standard drinks. The interesting thing about this is in the RSCGP Red Book, so that's the Preventative Activities book, in one of the appendices, they've got a alcohol screening questionnaire, the Audit C, and for the last 3 editions, I think, they actually have an error because they use US standard drinks in it, and no one's picked it up for quite a long time. Anyway, so it looks like risky drinking is common in the Australian community. It appears that there are a number of well-validated and so-called effective alcohol screening instruments, but GPs don't use them, and reasonably good evidence that we're not terribly good at identifying risky drinkers in our rooms. Looking at the screening questionnaires, they're the main risky drinking screening instruments. It's useful to sort of go back in time a little bit and sort of understand sort of the context of how they were developed. So, the very first screening questionnaire is CAGE. So those of us who are doctors would know about CAGE. That's still taught in medical school. It's the only one I know all the questions off the top of my head. Originally developed in 1970, and that green block there, which probably doesn't project very well, is DSM-3. And that's it's important to remember that over this period, from the late 60s up to 1980, psychiatry had a major sort of shift in sort of philosophic orientation from sort of a psychodynamic, psychoanalytic perspective, really to a much more empirical perspective. So DSM-2 looks nothing like DSM-3. DSM-3 had explicit diagnostic criteria, actually tried to define depressive disorder, alcohol use disorders, actually tried to define what those terms meant. For something like alcoholism, alcohol use disorders is actually a definition to that. Well, previously, what a British psychiatrist might call alcohol dependence or alcoholism would not necessarily be the same of what a US psychiatrist would call it. So CAGE developed in 1970 out of this feeling that the doctors at the time needed to find some mechanism of identifying people that wasn't just based on subjectivity. 4 questions. Have you felt you need to cut down, annoyed by criticism, guilty about your drinking, an eye-opener? And the original scoring was any questions positive was a positive. Developed in a hospital-based population of people with what we would now describe as alcohol use disorders, alcohol dependence. So described as alcoholism at the time. The problem with the CAGE, of course, is there's no time course to it. So anyone who had ever had, in the history of their lives, one of these things potentially would score positive. I scored positive on the CAGE. When I was travelling around Europe for 6 months, went to the Netherlands for about 2 weeks, and it was quite possibly where I was staying, but beer was cheaper than water in the Netherlands, and so it was the only place where I had beer for breakfast. I had to eventually stop doing that because I was tipsy by 10 o'clock in the morning, but I scored positive on the eye-opener. But the CAGE is somewhat problematic after when it was studied later, especially in community populations, in that it doesn't really detect people with milder range of drinking, so risky drinking rather than alcohol use problems. constructionally, it seems to detect people who think they have a drinking problem. So you might as well, rather than asking the cage questions, you could have just asked, do you think you have a drinking problem? That appears to be what cage actually detects. Still, very simple thing, still taught in medical school, I think. 1971, the Michigan alcoholism screening test, a MAST, came around, 25 items, very complicated scoring scheme. A few years later, they shortened that, so that's the simplified MAST, the shortened MAST. 1973, it went down to 13 questions with a simplified scoring scheme. And again, the whole rationale for making these instruments at the time was to more accurately identify and detect who had alcoholism, as was defined in that time. By the 1980s, the now still current paradigm through the WHO of early detection, especially in community practice primary care, so that you can intervene with brief interventions, hopefully avoiding alcohol-related problems altogether. That was sort of well underway, and there was a recognition that if we're going to do that with alcohol screening tools, that none which were useful or effective in primary care existed. So CAGE was sort of demonstrated to be reasonably poor in community practice, same with MAST and the simplified tool. A number of biometric type markers were used, but again, they're generally not very good. And so a big international project came underway to create a instrument that could be used in primary care, and that's the audit. So that's the question I demonstrated before. Involved 6 countries, 2,000 odd patients, originally 150 items, question items, over a number of different conceptual domains, tested in a whole lot of patients, and then shrunk it down to the questions I think gave the best psychometric properties. And then after this point, the next decade was about validation in a number of different primary care populations. So the audit came around in the late 90s after this initial idea that we needed something in the early 80s. Towards the 90s, the last gasp of the other screening questionnaires came around. So most of these involved rearranging CAGE or the Michigan questionnaire, so bits and pieces out of each in different populations. I think the TACE was specifically in women who were pregnant. But the audit has really taken ascendancy since then. So audit, or one of its variants, which is usually a simplification of the audit, they're generally the things which are still used now or used in research in terms of testing and validation. So the audit in itself is still used. The audit C is fairly popular. That's the first 3 questions, the consumption items. The British are fairly keen on FAST, which has a couple of questions, I think, from their consumption of one of the others later on. All right. These dots are different studies which looked at the screening questionnaires to look at uptake. Are people actually using them? And we've got pretty consistent evidence over time that nobody really uses them. Now, we all sort of know this. Like anyone who works in general practice will sort of know, do you actually use this? No. If you answer a questionnaire on whether you might have used it or not, you might, depending on how they ask the question, you might say yes. But most of these questionnaires that sort of looked at uptake of various different tools, they're all really low, and all those estimates are probably gross overestimates. So we know that no one really seems to use them. So reading through the literature, there's 2 very interesting sort of patterns and responses to this phenomenon that there's apparently this issue, this problem. We've created a bunch of instruments which appear to work in research settings, quite well validated, especially the audit and its variants, quite well validated. No one seems to be using them or implementing them in routine care. The first response has been fetish is too wrong a term, but this movement to rearrange or try to simplify the tools. So we saw from MAST to S-MAST, and then these guys are all simplified versions of some combination of CAGE and MAST. The audit with its 10 question items, broken down and repackaged into 3 items or 4 items. So this move to sort of simplify it. Now, from my perspective as a GP, where we sort of think about pragmatic sort of things, that never seemed to make very much sense to me. CAGE is really simple. It's as simple as it gets, really easy to remember in terms of the questions with the acronym. Scoring is simple. If you're positive on 1, it's positive. And evidence throughout from there to here is that no one ever used a CAGE except in sort of educational settings, or they might ask CAGE questions on a patient where they already thought they had a drinking problem and they're just using it as a segue into talking about drinking. No one used it for routine universal screening. So if no one used a CAGE, it seems a little bit problematic to expect implementation is going to be fixed by simply just making the tool simpler. The other response is trying to focus on education training and support. And I can naively understand why that might seem to make sense. Okay, if GPs don't know how to use the tools, teach them how to use them, provide some sort of practice support, maybe a practice nurse, maybe some funding to do it. But that is based on a fairly large assumption that the lack of routine implementation is related to a lack of knowledge or lack of training or a lack of support. And I'm not entirely sure that that's a very good assumption to be making after 3 decades of non-implementation. There's plenty of evidence of various instruments, various modes of practices being implemented in general practice very, very quickly. If it's perceived to be useful. So the computerization of general practice occurred within 5 to 10 years. The move towards having accreditation, again, there was a very, very quick implementation period. And these are all things that take a significant amount of time and investment. So the focus purely on education support training, so focusing on perceived deficiencies in the clinician themselves, maybe that's not going to be a fix for implementation, even if there does need to be education training and support. So what I looked at in sort of my research project in 2011 that crossed over into 2012. So at that stage, I sort of decided to do the master's project through the institute, and Nick was kind enough to be my supervisor at the uni side, a supervisor with the institute as well. Was I really wanted to understand this phenomenon a little bit better. So this is a poster, so rather than trying to describe something, I thought I'd just show the poster, it's a little bit easier. So the aim of that study was to, firstly, just to describe what Australian GPs believed about screening, about risky drinking. And I was particularly interested at the audit C at the time, but that actually ended up being not so important in that study. But just what were their beliefs about the detection and screening, and to understand why the low uptake. Okay. I think people have made lots of assumptions on why screening tools are not taken up, but how about just asking the people asked to implement them? What do they think about it? So so methods of this study was basically just focus group interviews of a group of GPs. Mostly this was a convenient sample of people I knew, so people working in training practices. Number of trigger questions, mostly used grounded theory for the understanding bit. I suppose it's thematic analysis for the description. And we found some quite interesting results. I won't go through it in very much detail. We'll just look at the central circle. But the GPs seem to really, when you sort of dug into what they said and the underlying explanations of sort of the words that they uttered in the focus groups, it seemed to take a very social perspective to drinking. So this is in terms of the barriers, why they found it difficult to to ask about drinking. Firstly, they sort of identify there is still this stigma of problem drinking, alcohol dependence. That forms a framework to all discussions, that asking about drinking or for patients being seen as having a drinking problem was something that was potentially very unacceptable, socially unacceptable. That led to the GPs having the feeling, the perception that alcohol's use history, so the information they got from patients about their drinking histories was quite unreliable. So for some GPs, they perceived this as a unconscious thing that patients might do, that they would tend to underestimate. And again, in clinical medicine, we sort of joke about this. You ask patients how much they drink, and what they actually drink is double what they just said. This is sort of a maxim. But for other GPs, they actually mentioned in the interviews that they thought the patients would consciously misrepresent how much they drank, so they would lie in the consultation, especially if they felt that there wasn't adequate rapport. And this worry, this fear that the discussion itself could be a threat between the relationship with their relationship with the patient, that they were worried about being seen as moralizing, they're worried about being seen as judgmental. They worried that that impact on the relationship would have ramifications to other aspects, to their care for the patient. Obviously, alcohol isn't the only thing, may not even otherwise be on the agenda for any particular consultation. So that's what the GPs thought, and it's sort of encapsulated well by this female GP who said, in quote, "It's socially unacceptable to say that you're a heavy drinker, but it's actually socially acceptable to be a heavy drinker," and that's the problem. So they perceived it very much in cultural and social dynamics, and also the consultation that had major impacts on how able they were to detect risky drinking in their patients. Now, I thought I was pretty clever and novel with that, but we'll see. We'll see a little bit later. So 2013, so back to my journey, was a pretty good year for me. I finished my master's at the Institute of Psychiatry, got this paper published, got Alan Chancellor Medal when I presented this at the college conference. The medal is sort of like a big coin, and it doesn't look shiny anymore. My one's all scratched up because my son discovered it one day, and it sort of started rolling it down the corridor. But it actually rolls really, really well, actually. So 2013 was a pretty good day. And as I said, when I sort of described this, I thought I was being pretty novel. There have been other qualitative work looking at GP beliefs and beliefs and attitudes towards taking alcohol histories to alcohol screening. Not in Australia, not recently, mostly in the Northern European and UK scene. But as it goes, when you sort of dig into the literature a little bit deeper, you discover that all your good ideas have been written by somebody else before. And so I found this paper from 1980 from a Canadian psychiatrist. Now, I'm not sure why his views were not taken up at the point, but this psychiatrist was sort of towards right at the end. He was still from the psychoanalytic sort of frame of thinking where psychiatrists are moved to in a different space. But he had some really good ideas, and I feel kind of wish I could go back in time and actually speak to him to what he thought, because I think he's got it right. So he had this paper, Hidden Barriers to the Diagnosis and Treatment of Alcoholism and other alcohol misuse. And it's probably hard to see, so I'll read it directly. So what he said 30 years ago, before I wrote my paper, these observations suggest that responsibility for the failure of early diagnosis and treatment of alcohol misuse in medical settings lies neither with the patient or physician, but with the relationship of their roles. And hence, in most consulting situations, the patient and physician cannot form a mutually satisfying relationship, and as long as it is not mutually satisfying, it is not likely to be therapeutic. And he wrote much better than me what I thought might have actually been going on inside of consultation, what the actual potential barriers were. For the first most of the 80s, while people were designing screening instruments, and I'll get to this point a little bit later again, asking what GPs actually thought about talking to patients about alcohol and having a greater role with the management of risky drinking, alcohol misuse, was actually something that was not done. There were almost no papers actually asking what GPs actually thought about doing this work in practice. And the first group of researchers, and it's quite a seminal paper, actually just went to a group of GPs and asked them, what do you think about this? Why don't you do it? Why not? And how can people done better? Was Tom and Tellers in the UK. And again, a number of really interesting ideas come out of it, which I think strike at the heart of some of the assumptions, which I think still underlie a lot of the research which is being published now. A little bit less so now, but it's still there. So, again, I just have to read that because I don't think that projects very well. The first bit, it has often been assumed that the failure of GPs to enter wholeheartedly into involvement with these problems is evidence simply of ignorance, prejudice, or wrong thinking. More often than not, however, discussion is based on the open or latent assumption that the GP's active involvement with this type of patient is a good thing. With few notable exceptions, little attempt has been made to seek GPs' views of their role in responding to alcohol problems or take their views on the difficulties they experience in attempting to do so. And the second one later in their piece, so this is looking at some of the responses from the GPs, so thinking about the whole education, training and support, doctors' replies indicated the beliefs that these approaches being education mostly in this context, merely emphasised the role of medicine in responding to drinking problems while ignoring the importance of wider social influences on the direction and outcome of medical intervention. So again, GPs back in the 80s, where in the 80s in the UK, I would argue that there was much less education on managing drinking problems back at that time. I think the medical curriculum has made some major changes since then. But even the GPs at the time, I think they recognised same sort of problems that GPs today still do now in terms of why is it that they have so much difficulty doing screening for alcohol problems. And going back to the audit, as I said, the audit, remarkable, quite a remarkable screening instrument in terms of how it was developed, in terms of the psychometrics of it. 2,000 patients, people not just from Western communities. The items are all designed to be culturally neutral so that you try to avoid some of the culture-bound questions which are in the MAST in particular. The audit was designed to be suitable for use in primary healthcare settings, in general practice settings, if it was in the UK or in Australia. But when you actually look at how was it made to be suitable for primary care settings, it was purely based on common sense notions. So during the design, they spent a lot of work trying to work out what the questions were, but how it was going to be implemented was never really a feature of its design. So never really asked the people working in primary care, GPs, never asked patients on what they would find acceptable as a screening instrument. And this had some major ramifications. When it was actually, so after it was developed, started being validated, actually being used in primary care to see how it would work, was it effective in pragmatic settings or not. So we find this. So this was a study where they actually were validating the tool in a particular general practice population, and after that, that showed that it seemed to work. They asked the GPs who were interested in alcohol research, who implemented this in their practices, what did you think of doing this? The doctors could not recommend a screening and brief intervention program, although they thought it was important to counsel their patients on drinking. Screening for excessive alcohol use created more problems than it solved for the participating doctors. The results underline the value of carrying out pragmatic studies on the suitability of seemingly efficacious healthcare programs. So in context, this was in a group of GPs who wanted to do this. This was a group of GPs who were testing the tool to validate the tool in their practice. And basically at the end they said, we just can't do this. We can't do it in our practice. It just interrupted our workflow too much. It caused too many problems with some of our patients. The literature's response to this paper from Beisch and colleagues is really interesting. There's lots of really angry commentary around that. And for the most part, I think people have sort of calmed down about it now. But the results of this study, which was an actual pragmatic application, was pretty much either ignored or denied in the literature for quite a long time. So looking back at my own study, there's in that little diagram there's an obvious black hole there, which is the patient bit, which would make sense from the context of this study because this was focus group interviews of GPs, not of patients. And so I sort of decided, well, what do patients think about this? So we thought, what the literature, what the researchers think about this. We've got some information about what GPs think about this, and there's a bit of discrepancy there. But what about patients? Because after all, we're asked for alcohol screening, we're asking a group of practitioners to implement a tool, but it will be the patients, it will be the community who will be the recipients of the tool. So what do they think about this? So I had a look back at the literature, and there is surprisingly little. In fact, there's almost nothing at all. There's only 2 qualitative papers, Stott and Pill and Locke. Stott and Pill's article was semi-structured interviews in a home of participants, a very narrow group of patients though. So these were mothers of what they described as lower socioeconomic class. They went to their homes, did some interviews on what they thought about being asked about their drinking from their GPs. And interestingly, although the participants would agree, so to the question, do you think GPs should be interested in your drinking? Oh, yes, of course. It was the context of that was very, very important, that it was only appropriate if their health could be directly or potentially affected by that behaviour. So for Stott and Pill, they sort of identified this phenomenon for patients. Yes, doctors should be interested, but, and there are a lot of buts to when the doctor should ask or could ask. Locke was another primary care researcher, again in a focus group of GP patients in an area of England that she claimed to have a strong culture of heavy drinking. She found fairly similar results to Stott and Pill. And again, these patients emphasised the importance of context. So whether they'll be happy with receiving alcohol questions, alcohol assessment, not dependent on why they were seeing the GP in the first place, why they're actually there. So, in 2013, I applied for a grant with the RACHP, so Royal Australian College of General Practitioner Foundation. Was successful in getting a small grant to do a study of GP patients, so actually asking patients to see what they thought. This is another poster I presented fairly recently, so rather than going through the study in detail, I'll just go through a poster, which was reasonably well. So, in this study, I had 3 major questions in terms of how acceptable patients found alcohol inquiries, so alcohol questions from GP in practice. So firstly, this question was kind of something for the college. So the college is very keen on this this idea of SNAP assessment. SNAP standing for smoking, nutrition, alcohol and physical activity. So for the lifestyle factors to be asked in most consultations. So one of the questions I asked is asking these sort of lifestyle factors within a SNAP framework, so health promotion type framework, is it more acceptable to patients than just asking about alcohol alone? Reading between the lines in sort of the literature, it will suggest it might be, but is it actually? So is the college right to advocate using a SNAP type approach? We heard a little bit about context. So why I'm at the doctor matters to what the doctor does in terms of asking them about my drinking. But what are these contexts? How does it matter? So do patients find it acceptable to be asked about their drinking in certain situations and not in others? And what are they? And how big is that effect? So I wanted to investigate that. And of course, qualitative work, what are their beliefs and attitudes? So if we find some quantitative stuff here, what is the explanations for those results? So what we did was we invited every single adult patient who presented to a GP, one specific GP clinic. We posted them one or two questionnaires. So this was a survey experiment. So that's how I tested whether one or the other was better. What they did on that questionnaire was they were given 20 vignettes of patients coming to see the GP. So the first one might, so let's say one on diabetes, a person with diabetes, a chronic sugar problem goes to see their GP for follow-up. The GP asks about how acceptable it is for the GP to ask about their drinking, and then it gets rated on a Likert scale. And for one group of participants, they rated just alcohol, and the others, they also rated how acceptable it is asking about smoking, how acceptable is it asking about physical activity, how acceptable is it asking about their diet. Okay, so either given as alcohol alone or within SNAP. And then for the respondents of the questionnaire, there was a spot they could leave some details on whether or not they'll be happy to be interviewed afterwards. And for those who were, we did some patient interviews to get them to explain what they thought, why they answered the ways in particular ways. So the results, so interestingly enough, even for something as blunt as a questionnaire, something presented just as alcohol or something presented with smoking, nutrition, physical activity, yes, people did find when questions were presented within SNAP to be more acceptable. That's ended up being a sort of a small moderate effect. Collins D of about 0.4. Major effect from the reason for presenting. So in the vignette where it was where someone coming in with diabetes for sort of diabetes checkup, almost 9 out of 10, or a little bit over 9 out of 10 patients thought that, yep, it's okay to ask about drinking in that setting. In the vignette about back pain, which was written as a low back pain scenario, so a person hurt their back, they're coming to the doctor because their back hurts. Something very simple like that. So there's not a lot of details in the vignette. It's very, very simple, written in about 5th grade language. Only less than half of respondents thought that it was okay for the GP to ask about drinking in that scenario. Given that very little bit of information, they thought, only half thought that was okay. And in fact, almost a quarter, a fifth to a quarter, thought that it was not acceptable for that to be asked. That's really interesting, and reasonable amount of variations. And these vignettes were constructed based on pretty much the top 10 reasons of presentation. So top 10 reasons why people came to see the doctor in Australia, and top 10 problems managed in Australia general practice. Then so that's all really interesting phenomena, but the qualitative work was what really allowed us to make some meaning, make some explanation on what was going on. And from speaking to those patients, it looked like there were 3 major in-consultation effects that sort of seemed to explain the variation in terms of whether someone would find it acceptable or not. And firstly, there was this perceived relevance of the alcohol dialogue. So whether or not the patient in their heads could somehow link the question about drinking or the assessment about drinking, the insertion of alcohol into the agenda of the consultation, into the reason why they were there. And if they couldn't do that, then they would perceive it to be were more likely to perceive it to be unacceptable. So this potentially explains why, when you ask people more generally, do you think doctors should ask about drinking? Do doctors know about patients drinking? Most people will say yes to that it's a medical problem, and most of our recipients answer in the same way. Yes, it's a medical problem, but when they were actually asked, if the doctor asked you in a specific consultation about your drinking, would it be acceptable or not? That general agreement, I suppose, that it is sort of a medical problem didn't seem to matter if they couldn't see relevance to them in the consultation. Now, the approach and the language did matter. So a lot of patients described that if the GP seemed empathic, seemed warming, seemed like the discussion was a negotiation, that they were helping to construct meaning together, that they would be more likely find it to be acceptable, and I suppose that makes sense. There was this talk of this sort of unease about the moral dimension, and the GPs have talked about it a lot, and patients here mentioned pretty much exactly the same thing on the other side, that they were worried about their GPs judging them. They were worried about being seen as someone with an alcohol problem, because that's a terrible thing to be someone with an alcohol problem. And this would sometimes compete with some of the others. So for some patients, if it's a GP who I trust very well, a long-term relationship with, I might be more willing to reveal something about my drinking. But on the other hand, at the same time, if it's someone who I know very well, then I wouldn't want them to think that I had a problem with my drinking. And so they were less likely to reveal. Similarly, one of the participants mentioned to my medical student who was doing some of the interviews that they would be more likely to reveal to him their drinking problem because he's a stranger, that there is no established relationship. If you judge me, it doesn't carry any social weight to it, as compared to revealing that to their GP. So this unease with the moral dimension is really interesting, hearing the patients talk about that. And interesting enough, a few of the participants mentioned explicitly that if they didn't feel that that the GP had permission or had authority to ask about their drinking in a consultation, they would in fact lie. They would in fact minimise what they say. I'll say I drank a couple, but I might underestimate what I say. So that was really quite interesting. So for the 3 questions in that specific study from last year, so SNAP versus alcohol alone, yes, alcohol within SNAP probably does improve how acceptable patients find alcohol increase, and it's probably because it implicitly sets the health promotion context and frames the dialogue, perhaps. Reasons of presentation, major variations. So the assumptions that patients will find alcohol dialogue acceptable should probably not be assumed. And that is generally assumed in most documents which suggest universal routine use of alcohol screening questionnaires. And patient beliefs and attitudes are quite complex, quite complicated, related to sort of the 3-factor model before. Now, there is a pretty large limitation with my study, and it's it's a limitation that's actually very common to all the evidence that's out there. Almost all the patients in that study were either born in Australia, North America, or the UK. And if you look at the research looking at patient attitudes, GP attitudes actually, as well, they generally come from countries which are described as having a morally ambiguous or temperance type culture to drinking. So where drinking is, so these are countries described as dry countries, as opposed to wet countries like Italy or France. And that sort of makes a bit of sense in that the countries that have a social moral problem with drinking tend to do most of the research looking at drinking. But when I look at where I work in Fairfield, over 2/3 of the population, close to 3/4 in fact, speak English language other than English at home. close to 2/3 of the population in and around Fairfield and Wetherill Park were born overseas. We know absolutely nothing about what a Iraqi thinks about being asked about the drinking with a doctor. We know pretty much absolutely nothing what the Assyrian population, which is there's a large population around Wetherill Park, what they think about alcohol. So if we're going to use information to design implementation strategies, I for one think that the screening instruments have a role. How they're implemented in practice, I think that hasn't been cracked, and we need to know what patients and GPs think about this to make it work. We really need to know what the cross-cultural perspectives are towards alcohol discussions in practice. So 2015, so this year, what we're doing underway at the moment, we're doing a fairly large cross-sectional survey up to about 20,000 patients in the Fairfield LGA area. Looking at, so utilising sort of the instrument we developed with the survey from last year, and looking at some additional questions, trying to understand sort of social context, whether people have sort of critical, projecting critical views about drinking, and whether that has an effect on how acceptable or not acceptable they find assessment about their drinking. And again, with this one, we'll be asking the participants to nominate to sit in for further interviews, and so potentially we could get some really rich data from very specific groups. I'm almost done. So this is the paper that we just got published. To move the field forward, the beliefs and attitudes of GPs and especially patients towards alcohol discussion need to be explored, understood, and used to inform early detection practices. And I think we've had a missed opportunity for about the last 30 years with how the research agenda has been so focused on the psychometrics of screening instruments rather than the implementation. Thank you. Victoria?